emotionally taxing for these women, and then to say, we don't know why. I mean, women walk away, more so women than I think men, right?
Yeah.
They walk away thinking they're broken. There's something wrong with them.
Exactly.
There's always something wrong. It's never idiopathic. There's always a reason, there's always a cause.
Yeah.
And it's about finding what that is, digging deeper. Because nothing's idiopathic. Nothing just happens or, we don't know the cause. There has to be a cause.
Yeah, well,
We're not supposed to get sick.
and to say to a patient that there's no explanation for their infertility, you're doing so much harm.
Oh my
Because
gosh,
then
for sure, yes.
They will keep asking themselves, what is it
Yes.
I am not doing
Yes.
to fix my problem?
Right.
And take ownership on it. And I actually think that that's a little bit cruel.
It is terrible. It
Like,
is.
sorry, we can't help you.
Right.
Because we're very task oriented as healthcare professionals, and we
Mhm.
say to them, okay, it's unexplained. But you're the experts.
Right.
What do you mean? It's you don't know? That's why I'm here.
Right.
Right? And
Yeah.
that's hard. I think that's really
It's
hard.
very hard. It's very hard. It's very mentally taxing. So we kind of brought up 30% plus of all infertility is unexplained. But when you look at nutrigenomics testing, what we're looking at is we're looking at vulnerability of that patient to oxidative stress, to hormone metabolism, to specific drug and even nutraceutical recommendations specific for that patient, and also lifestyle and dietary recommendations that will be specific for that patient. So this is really personalized medicine. Everybody talks about treat the whole person, treat the person. Well, you can go in for, infertility treatment, but is the standard of care the same? It might not work for every single person because of genetic abnormalities. There are things that you can do to maximize the effectiveness of certain medications as well. So this is truly personalized medicine. And this is definitely the wave of the future. I mean, we talked
Yeah.
about that too because, with, the internet, people want to know why. People want to know what is going on inside their body. So this type of medicine is definitely consumer driven.
It is very consumer driven. I was at an infertility symposium in Vancouver. I told you
Mhm.
about this, and there was a presentation there. And the thing is, you can hide from genomics, but it will eventually catch up to you.
Mm-hmm.
And we just had a great talk in the main room about that. It was a bit, 30,000 feet. I was hoping we'd get down to 5,000, but we didn't quite get there. But the reality is, with 23andMe as an example,
Mhm.
people are doing their own genomic testing. They
Right.
come into you with their results,
Yep.
and they say, can you explain this to me?
Mm-hmm.
And you're like, maybe, right? So,
But see, with nutrigenomics, this is taking it one step further because this is looking at the phenotypical influence on that gene. Just because you have a 50% increased risk of developing hemochromatosis doesn't mean that that gene is going to manifest. That's the environmental influence on that particular gene. So that's looking at the chromosomal abnormalities, but then looking more specific to the 70,000 genes on those chromosomes. So that's really looking at the phenotypical influence on that. And I think, we talked about too, the more information you have, I think the better you can make a decision. I remember a long time ago, and this has stuck with me a long time, I had a patient, she was a teacher, which is a super hard job, so she had a lot of stress. And she had she had a genetic disease that she's gonna die of cancer. She had 3 different forms of cancer. And the incidence of passing it along to kids was of her offspring was 80%.
it's crazy.
Would you have kids? She did. I don't know that I could do that. To each their own. But to know that that is going to be something that you're going to give your child, and again, even with this stuff,
Yeah.
There's things that you can do from a nutritional and supplemental standpoint,
Yeah.
but I think the more information you have, the better you can make a decision. I really do. And this really is, like I said, personalized medicine. So when we look at all the different gene variations or SNPs that should be considered in fertility management, there's a handful of them out there. And I did bring some genetic testing results. I can, show you guys when we're done or whatever. But so when we look at gene variants, how many of you have heard of Mthfr? I mean, that's like the hot thing, okay? Well, like really 1 in 4 people have it, okay? And, everybody comes in to the, I have the MTHFR, this is my problem, I know that it is. Okay, maybe not. It could be, it might not be. So when we're looking at gene variant with the MTHFR enzyme, essentially this is looking at all biochemistry stuff, okay? And if you have a genetic SNP in the MTHFR, it decreases enzymatic conversion of folic acid to active folate. And ultimately, that requires, a couple of different things to kind of bypass that. Again, just because you have a genetic SNP on there doesn't mean that that's going to manifest or cause any issues, okay? But it can cause high homocysteine. Homocysteine is an amino acid that the body makes naturally, and if you have a genetic SNP in the MTHFR, you can't convert homocysteine to methionine, and this increases risk of stroke to baby, which can increase risk of miscarriage. So essentially it kind of causes clots, but small enough where, it causes issues with baby, nutrition to baby, but not to mom. So that's essentially how that mechanism works. And then also the utilization of active folate, to prevent neural tube defects, HPV, viral replication, and kind of things that way. So there's also a genetic variance for vitamin D. So people take a lot of vitamin D sometimes. I mean, we all should be taking a lot of vitamin D, or at least, first of all, getting your vitamin D levels checked. But just because you take a lot of vitamin D, I have had patients so many times, they're taking a ton of vitamin D, and a year later, their vitamin D levels went up 10%. It's like, what is going on with that? Well, if you have a genetic SNP and the VDR receptor gene, this is what actually activates vitamin D to the bioactive form of calcitriol, which is what the body needs to absorb calcium. So you can take vitamin D in. Is it doing what you need it to do? We don't know, okay? So again, looking at these genetic variants can definitely help. BCOM1 is looking at the metabolism of beta-carotene into vitamin A. We know vitamin A is important for cell growth, embryonic development, and also organogenesis of baby. It's important for the cilia function in the fallopian tube, so moving that egg down and getting ready for the sperm to come on up in there, and also for sperm production. So if there is a genetic SNP here, that can increase risk of infertility, miscarriage, and you can take vitamin A, but sometimes, again, if you have a genetic variant here, that might be the best way to do it because beta-carotene just won't work, okay? B12 will play a role in, folate metabolism, so you have the TCN2 genetic SNP, the FUT2 genetic SNP, and then the MTR, the MTRR, and a lot of this has to do with methylation, using B12 recycling, the incidence of high homocysteine, and then also B12 absorption in the gut. I see a lot of pernicious anemia, and I see it in people taking B12. That could be due to, they're on PPIs, decreasing stomach acid. That's going to cause B12 deficiency in the cell. And even checking B12 levels in the blood, a lot of times it's high in the plasma, and that's because it's in the plasma, it's not in the cell. Well, the vitamins have to get in the cell for the body to benefit from it. Having genetic variants in these can also cause poor pregnancy outcomes, miscarriage, spina bifida, and also maternal obesity, gestational diabetes. The NQ01 is a gene variant that is involved with CoQ10 metabolism. This gene makes a version of CoQ10 reductase